Welcome to Pediatric Consult. I am your host, Dr. Jill Schaffeld, and I'm here today with our two guests, Dr. Nancy Crimmins and Dr. Amy Shah from the Division of Endocrinology at Cincinnati Children's Hospital. And we will be talking about prediabetes and type 2 diabetes, and more specifically, the diagnostic dilemmas that they can present to the general pediatrician in the office. So let's start and learn a little bit about our guests. We'll talk to Dr. Shah first. Just a little bit about yourself, how long you've been practicing at Cincinnati Children's, how long you and Dr. Crimmins have been working together, and even just sharing some special interests.
Okay, great. Well, it's great to be here. I have been doing pediatric endocrine since 2007, so we're going on about 15 years. I actually came to Cincinnati Children's to do my fellowship training and then stayed on as faculty. I am director of the type 2 diabetes program at Cincinnati Children's. Dr. Crimmins actually heads up the pre-diabetes program. So we've been working together since I started probably my fellowship a long time ago, but more closely probably over the last 5 years.
That's wonderful. Do you have any other special interests besides type 2 diabetes that you want to share?
Well, I actually spend a lot of my time in clinics seeing patients. I also actually work in the preventive cardiology clinic, seeing patients with primary and secondary lipid disorders, as well as pediatric hypertension as well. And then I spend a lot of my time actually doing research too. So trying to understand complications of diabetes in the pediatric age range, and then specifically how best to manage this population of children.
Wonderful. I think that's such a great example of how integrative Cincinnati Children's is, working with the cardiology clinic too, in terms of prevention, right, for diabetes and prediabetes. So Dr. Crimmins, same questions to you. How long have you been practicing, if you would like to share, and then how long at Cincinnati Children's? And then Dr. Shah mentioned that you guys have been working together since 2007, which is great.
Yeah. So I came here for residency in 2000 and stayed for fellowship and on. And even early in fellowship really developed an interest in how we prevent type 2 diabetes. So there's this thing like preventive cardiology. There's no preventive endocrinology, but I almost think there should be. So we established this prediabetes clinic to really catch kids before they're tipping over and try to be aggressive with lifestyle management. And then I run a clinic with the HealthWorks group for kids under 6 with either early onset or severe weight issues, and really to try to capture those kids early and be really aggressive in management, because we know where they're going to end up if we don't. And fun fact, I actually interviewed Amy Shah when she came for fellowship. It was like massive snowstorm, and she got stuck at the airport till like 2 a.m. And so we were on the phone very late at night. So it's really cool that we had that experience, and then now that we're partners, like,
sure.
I love it.
After that, you're probably like, yes, we need her.
We were kind of bonded a little early.
We were.
That's cool. And it's cool that you guys have continued to be able to work so closely together.
I always say Dr. Crimmins is the reason I came to Cincinnati Children's.
Aww. Nice. How much did you pay her? No. I'm teasing. So just to go ahead and delve in, one little fact as I was reviewing Cincinnati Children's, we have our community practice support tools that I think both of you were involved in developing, our prediabetes and type 2 diabetes. You know, I looked and I saw a stat that was pretty staggering that said 5,700 new diagnoses per year. And is that, just curious, is that fact, is that age range under 18? Kind of what population are we looking at there?
Yeah, so some of that data comes from the Centers for Disease and Prevention, and there was a large study across the United States, and it really is referring to youth under age, but in this case under age 21, wow. With diabetes diagnosed before the age of 18, though.
Okay.
And that's where that statistics come from, and that's primarily focused on new diagnosis of type 2 diabetes. Pre-diabetes might actually even be higher, and it's thought that maybe 1 in 5 teens might actually have pre-diabetes.
Wow.
And that's the latest data.
Pretty impressive, kind of mind-blowing when you think about it that way. 20%, right? Yeah. So, another thought, just discussing the incidence, and maybe Dr. Crimmins, you could speak to this, of just diabetes and pre-diabetes, the rise in incidence over the last 20 years.
Yeah, I mean, I even think during COVID we saw increases in all diabetes and pre-diabetes for reasons we all recognize, just inactivity, eating at home, eating a lot of processed food. The obesity epidemic's just really been something that we haven't quite gotten on top of, and there's a lot of societal reasons, I think, for that are just hard to address. But I think, too, there's the big numbers in individuals, and families that come in, and I think we have a real opportunity to make a difference, each and every kid and family that come. And so it's easy to kind of be overwhelmed by the numbers and feel kind of like hopeless that there's so many things that are contributing to this picture. But I think we're learning new tools all the time and different ways we can help out. So,
absolutely. So what specific risk factors, and I think we can speak to pre-diabetes, and that will obviously overlap a little bit into type 2 diabetes, but what specific risk factors do you think, as a general pediatrician, we should be most aware of as we're having that conversation with the patient in the office and we're reviewing growth charts and BMIs and dietary intake, as well as, maybe just different lifestyle things?
Yeah, I really encourage people to take a good family history, and I think we're all kind of bad about doing that. Like, we take it when they're initial patients, and then we don't really ask again. But one of the biggest factors is, does diabetes run in the family? Because it's definitely has a genetic component to it. And so if you have a parent with diabetes or a grandparent, and a lot of times if they're like, oh, grandma has it and she was diagnosed at this age, I'll ask the parent, have you been to a doctor recently? Because we know a lot of the adults haven't been. They might be, it was like 8 years ago or something.
Such a good point.
Yeah.
They may say, I don't have it, but then, like you said,
they haven't really, been seen. So I do think it's really important to ask that question at least once a year. And some practices, I'm sure, are good about doing that and have forms or whatever, fill it on the tablet and things. But I think that's a huge risk factor. So, of course, weight is one, but it actually doesn't correlate as well as you would think. And then we're learning a lot about fatty liver, actually, as a risk factor. And I don't know how familiar pediatricians are with that process and screening for that. But those two physiologic processes seem to be pretty linked. And so making sure that they're getting screened with an ALT at least. And if that's, something that they develop first, we find that's a risk factor to develop diabetes in the future. What am I missing?
No, the only other thing I was going to add was moms that might have had diabetes during pregnancy. So gestational diabetes is another big one to ask about. And then, of course, physical exam,
Sure.
Any signs that you can see of insulin resistance, specifically acanthosis nigricans on the back of the neck is kind of the things that we think about the most when we're screening, thinking about who should we screen for diabetes or pre-diabetes.
I think that was great. I do feel like once we get through the newborn period, we don't a lot of times think to ask back again about pregnancy history. Yeah. We may be looking at a 10-year-old.
Right.
Oh, wait, that's significant as well. So, yeah, thanks for that clue on gestational diabetes and mom as well.
We did forget one thing, and then also race. So,
yes.
So minority races have a bigger chance of developing diabetes down the line than whites.
Okay.
Yeah.
Great. Thank you. Just to kind of piggyback on what you had mentioned, Dr. Crimmins, about fatty liver and being, it sounds like maybe even more of a predictor than even weight at times. Would you like to just touch very briefly on kind of diagnosis and
of fatty liver?
Uh-huh.
Yeah. So fatty liver is actually really tough because ALT is probably your best easy screening marker, but it's not perfect. I mean, really the only way to truly diagnose what's going on is a biopsy, but of course we're not going to put all these kids through there. So ALT is a good pediatrician screening marker, and if that's elevated, especially if it remains elevated, I know our liver friends, if it's over 100, they want to see those kids right away. If it's kind of in that middle group, over 50 for several times in a row, spaced out, then they like to see those kids too. The lifestyle treatment's the same, actually, for prediabetes and fatty liver. It's all low glycemic index type talk of cutting out sugars and then activity.
Increased activity.
They do have some imaging tools that they're using now. There's a specific MRI that can kind of help determine if there could be scarring or not. And they have a little ultrasound. What's that thing called? FibroScan?
FibroScan, yeah.
Yeah.
Oh, wow. Okay.
That they'll use sometimes in the clinic that isn't perfect, again, but can give you a hint. Because, of course, we don't want to biopsy every child that has an elevated ALT.
Well, and thank you for entertaining that, because I realize that's not specifically your specialty, but I thought with that being such a big risk factor to just delve into it a little bit. So I really appreciate that.
The only thing I'll say is I think we don't know which comes first, and in some patients one appears to come first, and in some patients actually you can pick them up at the same time. And of course, type 2 diabetes can also lead to fatty liver disease. So I think what we've seen is they go very close hand in hand, but which one may come first might depend on the individual patient.
Sure. So let's go ahead and talk a little bit about testing and just kind of general screening labs. I think most general pediatricians feel pretty comfortable with, what do we consider kind of our obesity labs or our prediabetes type screening labs. But would one of you like to maybe talk a little bit about, just as a quick reminder of kind of what labs make sense, maybe even labs that have been ordered in the past that really aren't needed, what to focus on?
Sure. So the easiest thing to do is just a fasting draw, because you're getting your lipids at the same time. So a fasting glucose, which is a criteria for both prediabetes and diabetes, and then a hemoglobin A1C measure. The one that we used to do more is insulin, and over the years that's really fallen off as a recommended screening tool. And the reason is because it actually doesn't correlate great with who's going to develop the beta cell failure part, like the blood checker part. So you can have insulins that are crazy high, and that kid never has a glucose issue. And then there's some finicky things about the assay and puberty that can affect it and things. So we don't really recommend insulin anymore. You can get an oral glucose tolerance test. It's just more cumbersome, and especially in a gen peds setting to get, but that's really been the gold standard of diagnosing these two things.
But we've even swayed a little bit far away from oral glucose tolerance testing, because hemoglobin A1C or a fasting blood glucose level has been good enough in most situations.
Great. And that's what I was going to ask you, if there is ever a situation or a scenario that you can think of where you would say, oh, these labs are a little off. Would it ever make sense, really, in this day and age for a general pediatrician to order an oral glucose tolerance test?
The only situations I can think of is if you have a patient that really has no symptoms of diabetes, and there's some discoordination between it's a truly fasting blood glucose level and the oral and the A1C level. That might give you some more information. But in general, I would say even our division is ordering fewer and fewer of these tests and really limiting them to if you have specific questions you're trying to answer.
Great.
Yeah.
Would you agree?
I do agree. I think the only other time I might use one is, it is helpful if you have one of those kids that you're like not sure if it's type 1 or type 2, and you're kind of catching them on the slide, because you do get insulin levels during that test, and matching those up with the glucose is actually as gold as you think it might be, but it's still helpful to know how insulin deficient they are, and then again kind of what that glucose pattern looks like as they're developing disease. But again, I can't even tell you the last time I've done one, to be honest, because it's just hard to get the families in and do it, and you don't want to delay a diagnosis when you have easier screening tests to use.
Sure. Yeah. No, I think that makes perfect sense. So, we have the labs, we order the labs, and then what specific criteria, and we can start with even pre-diabetes, should we be looking for to diagnose or to say, okay, we're in kind of the pre-diabetes phase of things?
Yeah. So I'll take that one. So pre-diabetes is tough because there's multiple criteria, and in kids, less so than adults, it doesn't necessarily mean you're going to tip over to type 2. So sometimes you'll see a pre-diabetes marker and then you'll repeat it, and even though the weight's no different, it's normalized. So it's not that you shouldn't take it seriously. I'm definitely not saying that, but it's a little trickier than I think type 2 is.
Well, and I realize I used the word phase, and I'm like, that's not a good word because not everyone that has prediabetes is going to develop type 2 diabetes.
Right.
Right? But just kind of thought, I didn't really love my choice of words there, so thank you for
it can
clarifying.
be. It can be. It's just
Sure.
hard to know which ones, are going to kind of persist. So certainly if you have more than one thing in the prediabetes range, that's more worrisome, I would say. So your criteria are a fasting blood sugar between 100 and 125. 126 is your diabetes criteria. And then A1C between 5.7 and 6.4. So those are the two quickest ones that we do. And then on the oral glucose tolerance testing, the fasting criteria is the same. The 2 hours would be, or the 2 hour mark would be between 140 and 199.
Okay. And for type 2, it's just above that.
Yeah, it's above that.
Makes sense.
Exactly. Yep. So you can use all the same labs that you would have obtained. So fasting blood glucose level, hemoglobin A1C, and as we said, rarely the oral glucose tolerance test value.
Perfect. Are there, and this is kind of a weird question, but any additional kind of just red flags that we should be like, when we see these lab results, not to just say, this is prediabetes or this is type 2 and, I need help from an endocrinologist, but red flags either in the lab results or maybe even in the exam when we're seeing the patient?
Yeah, I can answer a couple of those things. So I think if the patient has symptoms, we get more concerned, right? So they're waking up at night to use the bathroom, drinking a lot, peeing a lot. Those are things that tell you the blood sugar's running a little bit higher, because really to have symptoms of diabetes, your blood sugar's probably been high for a little bit longer period of time. I think the hardest thing at this age, though, is the overlap with type 1 diabetes. So that's a really, I think, an important thing to bring up, because I think the age overlap is very similar, and you can have patients that have family histories of diabetes, and a lot of times they don't know if it's type 1 or type 2 diabetes. And so if there's any history of autoimmune disease, or if there's been, the patient looks a little bit sicker, I think you always have to entertain the diagnosis of type 1 diabetes too, because we definitely have patients with type 1 diabetes that can have BMIs that are in the overweight and obese category. You can also have patients with type 2 diabetes at onset who have had dramatic weight loss. So you might not see that extremely high BMI. So I think one of the things that I would always caution, pediatricians about is you can't just by looking at the patient know whether this is type 1 and type 2 diabetes. I think there's things that point you in the direction of one versus the other. But that's the other thing, that if there's any concern, that would be a reason, or a red flag to give an endocrinologist a call on the phone.
Well, and I love that you pointed out the, polyuria, polydipsia. We're just traditionally always trained that's type 1, that's type 1. Mm-hmm. So just to remember that can happen in type 2, especially like you said, if that glucose has been high for that long, it's going to have those similar effects in the body. So I think that's a good thing for us to keep in mind.
No, I totally agree. I think we've seen several kids in the clinic who've lost a lot of weight before they've gotten to us, and they're doing some of the things you said. So like they're celebrating themselves, and it's always like a little sad, I think, than when because usually they're the ones that have the highest glucoses and the most progressive disease.
Sure.
So certainly if you see somebody who's losing weight a lot faster than what you would suspect, even if you'd screen them within a year, I'd probably do it again just to make sure that it's not from hyperglycemia and that's why they're losing.
That's actually a great lead-in. My next question was just going to be, if prediabetes is noted by the general pediatrician, say on lab work, what do you recommend for follow-up time frame for labs? And maybe part of that just depends on how many things are abnormal, right? I know it's a little bit of a broad question, but just how many months in between labs, and then at what point is it just once we cross into that true type 2 diabetes that we should talk about referral to an endocrinologist?
Yeah, so a lot of it just depends on how passionate the pediatrician is about these things, like, to be fair, because HealthWorks is a great program. That's our tertiary weight program here, and we have a whole visit to talk about lifestyle management and change. We have dietitians, we have exercise physiologists. So I think in the community the tendency's been, this is what we got, and we send them on to either endocrine or HealthWorks. But there's a lot you can do, I think, in the office, even in a short period of time. And I always tell the residents, like, I'm not sure handouts ever did anything. I'm not telling you not to give them. But I've never heard a family come and go, oh my gosh, I had no idea what to do until I got these handouts. And now I totally know. So I'm not trying to be mean. I'm not trying to be mean at all, because I think we feel like we're doing something good. But, you know, what I'm always teaching the residents who rotate through is, like, if you can even just get some idea of what that family's life is like, you might have a better idea of kind of where to start. Because a lot of our families rely on free meals, like, through the school.
Sure.
So spending a lot of time on healthy breakfast and this is just not kind of where, you want to start. And it's making sure you're getting a healthy snack after school and dinner. And it just takes some practice, I think, to do that efficiently.
Sure.
But those are things that you can absolutely do in the office, especially if you just have something right over the cutoff. You know, the kids' fasting's normal. They're 9. Their A1C's, 5, 7. Like, that's something you can talk about as a launch point. And then in that kid, if they're really buying in, you might bring them back in 3 months to really talk again and how's it going and recheck. Or someone who's really close to that diabetes line or has a lot of barriers, that one you might want to refer. I think sooner, because you have such a risk of tipping over and you need to be more aggressive.
It's interesting that you said, that about handouts, because one of the things I always try to talk to my patients about is, especially maybe when we're talking about a nutrition referral, I always kind of look at the parents and say, I know you know what healthy eating means, but how do we make that work in your life, right? Because everyone's situation is so different. And also for the child, how do we make that understandable to them? Depending on age, right? That can be so different. So it is interesting to think of it kind of from their point of view, because there is just so many different situations.
Oh, for sure. And I think you get, like, when they come to the general pediatrician, they may be there for any number of reasons. Like, that's if it's a well child check where you're really focusing on, on weight and growth. But the older the kids get, like, and you guys would know this better than me, but, like, I think sometimes they're coming in for a completely different reason. They have otitis, they have something else. Sure. And being able to capture that family at that visit and say, hey, you know what, I'd really like to have another visit to talk about this. What are your feelings about it? What are your thoughts about your child's weight? And really see where they're at with that. But you guys have so much to cover in a short time. Sure. When you're doing those well childs, that I really think it needs its own visit.
Absolutely, I agree.
The only thing I was going to say was, so I think with prediabetes, you have the opportunity to potentially intervene and recheck labs in either 3 to 6 months, kind of time frame. With type 2 diabetes, we really don't have that luxury. It can progress really fast, and they really need to be aware of the diagnosis, screened for other comorbidities potentially, and started on treatment. So I think depending on where those labs fall, you either have the opportunity to give them a little bit more time or refer right away.
Perfect. Thank you. And Dr. Crimmins, you had mentioned HealthWorks as well. Can you speak a little to, actually, Dr. Crimmins or Dr. Shah, who is the perfect patient that would go to HealthWorks versus, nope, we're going straight to endocrinology? Right. And it may be a little bit of what you kind of just touched on, but just to be very clear.
I'll let Nancy cover this, because she's been working on on this and making it better for several years.
Well, I'm trying.
You look like you're getting real comfortable in your chair.
No, so I'm the only endocrine provider that works in HealthWorks too. So I've really tried to bridge this, and I think we have some even better things coming down the line that'll bridge the two groups. But we just don't have the bandwidth in endocrine to see all these patients. So HealthWorks is run by general pediatricians, but they're fantastic. Obesity and their complications, that's what they want to do. And again, you have the dietitian in there, you have an exercise physiologist. So they are very comfortable with screening for prediabetes. They're very comfortable with even early type 2 management and how to do that. So really the kids that we want to go there are the ones that are the lowest risk to tip over, and we can kind of talk about what that means. But just know that if most of them really should probably go to HealthWorks, and just know that they know what they're doing. They're gonna get them over to us. We have direct pipelines going both ways, between physicians to make sure they're getting the right place. But even the cornerstone of type 2 diabetes management, it's lifestyle. So we have these fantastic drugs now that we didn't used to have, but that's still the cornerstone of what you're going to do with these kids, and especially in prediabetes. The ones we want in endocrine are the ones that are just a little higher risk. So the A1C is over 6, so you're getting close to the line. There's a strong family history, or you're like, man, this kid might be type 1. Like there's both types in the family. There's some just flags that make you a little squirrely. Like those would go, to endocrine. Or if there's NAFLD or there's a minority, the patient's a minority and older, and you just think those are the ones that you're more worried about. And that way, if they do have type 2 diabetes by the time we get them, because things have progressed, the team's right there. It's the same people who see the prediabetes and the type 2 patients. And so the patient's already rolling, in the system.
Great.
What do you think?
No, I completely agree with you. I think we kind of, depending on the patient's needs, sometimes they'll even get a referral and they'll look at it and they'll say, how about maybe this patient should go to you guys, and same with us even before the patient hits the door. So I think we're in communication on the back end. But what we usually try to say is refer to one, not both, because I think families get overwhelmed, and we are very, very similar in what our initial visits are like, especially for prediabetes. So I would say you really can't go wrong if you pick one or the other. But in general, I think one or the other is the best way to go.
And then we have the dietitians and the exercise physiologists in our clinic too. And we said it that way because before we had the clinics, if they were referred to endocrine, and I think people thought they were doing well, they'd be in a clinic where there's no dietitian or exercise physiologist there. And so you're seeing a doctor, and you may not even be seeing the doctor that does the most, diabetes spectrum work. So we have developed these prediabetes clinics for that reason, but I think it confuses people a little bit when they know that that's out there, that maybe then all the prediabetes patients should go to us.
Sure.
And that's definitely not how we think it should be set up.
Great. Are there any other specific things that you guys can think of that you would just little pearls to give general pediatricians? I think we've got some great info here, and just for our Cincinnati children's colleagues, can definitely refer back to, we talked about our community practice support tool has some very specifics and great flow charts to follow, good algorithms in terms of, what was that exact number that I'm remembering, and kind of where to go. But I just didn't know if there were any other little things to share. I think we've covered a lot, and that's okay if there's nothing.
No, I think the only other thing I would say is it's really what we don't know, and the biggest question is who might tip over from prediabetes to type 2 diabetes. So I definitely think these children need to be followed, whether it's with their primary pediatrician or with either the HealthWorks team or the endocrine team, really, because I think there's still a lot to be learned. But as Dr. Crimmins said very early on, I think we don't know which kids are going to tip over, and a lot of them don't actually. With implementation of diet and exercise, we've seen really good results, and some people, their labs completely can flip over to normal. So I guess I would say is, we're seeing more prediabetes, we're seeing more type 2 diabetes, but there's still, I think, a huge role for diet and exercise in both of these conditions. And even patients with type 2 diabetes that have managed to implement really good lifestyle changes and even bring their weight down, at times they can move that A1C into the prediabetes range, and we've even seen it revert back to in the normal range and come off of medicines.
Well, that's great news. Yeah. Great news for families and patients.
Yeah. The one thing to be aware of is every once in a while we'll have pediatricians have a patient that screens positive for type 2, and even sometimes pretty far down the spectrum, like that A1C is pretty high, and they put a referral in to endocrine. That can take months. We're pretty backed up, unfortunately. So that's, I just want to add too that if you have someone who's definitely in full diabetes, just contact us directly through Priority Link or however, for other people listening, you get a hold of your friendly endocrinologist, because we can get those patients in sooner, and we even have a day hospital program to bring them in immediately and get things going. And we don't want them, floating out there for a couple of months and not making it to us if they're already in type 2 diabetes category.
Yeah, so to go back to one of your questions you asked about how soon we should see the prediabetes, for type 2 diabetes, we want to get them in within a month, just to kind of share that information. So if there is somebody, feel free to give us a call, because we will manage to do that.
Wonderful. Yeah, thank you. Well, it's been a pleasure talking to you both today. Appreciate all the knowledge and help, and I think we've covered some great and very pertinent information. And I just wanted to mention as well that CME credit will be available. There should be a link on the actual podcast site at the end of this. So for everyone listening, nice little bonus there. But we appreciate everything, and I apologize. We heard some little beeps. There may be a delivery truck outside today or something. But thank you, Dr. Shah. Thank you, Dr. Crimmins.
Thanks for having us.
Yeah, thanks for having us. It was great.